Good morning, everyone. Dr. Dwaipan, it's always a pleasure to honor your invitation. Thank you so much. I look on you as a friend of many, many years. I'd also like to thank Dr. Virk, Dr. Haldar, Dr. Mujumdar, and Dr. Arunabam for being there and consenting to moderate this session. I'd also like to thank, I think, Dr. Saroj, Dr. Singh, Dr. Ravi Shankar, I think Dr. Jha, Dr. Malik, Dr. Maure, Dr. Gupta, and Dr. Ashok Naik. I hope I'm not missed out someone for moderating from the various centers. So today we're going to talk on I'm going to show a case of inverted papilloma. It's a C by the Kennedy classification or a T4 tumor because it has gone into the extra paranasal sinuses. So there's a question of whether there's erosion of the hard palate. That's a little bit of a query, whether the tumor itself has eroded, but there's an erosion of the hard palate, there's an actual involvement of the nasolacrimal duct, and therefore it is a T4 lesion. My assistant professor, Dr. Shivali, will tell you a little bit about the case.
So, good morning everyone. So, this is a 64-year-old male patient with complaints of left-sided nasal discharge since 2 months, which is blood stained. Then there is left-sided nasal blockage since 8 months. There is one episode of nasal bleeding, 5-month-old, which had stopped on its own, and there is excessive watering from the left eye since a week. On examination and anterior rhinoscopy, there is a polypoidal mass in the left nasal cavity reaching anteriorly up to the inferior turbinate. We'll discuss the CT scans with Madam now.
Yeah. So let's have, inverted papillomas or anything which is involving, especially when we feel that it's involving outside the sinuses, then we do both a CT scan with bony windows, CT scan with contrast, and an MRI in which we prefer to see a T2 as well as T1 contrast, and if possible, a stir. So let me show you what I'm looking for. We're not going to discuss the whole scan. I'm going to just speak on very relevant points. Okay, so first thing is, it's quite anterior. That's the inferior turbinate, and that's the inferior turbinate, and you can see already the nasal cavity is full of mass. And as we go posteriorly, you find that the nasal cavity is full of mass, but there is also an area which is not enhancing with contrast. That means there's a fair amount of secretions in the ethmoids over here. And as you go further, you can see that this is the mass, and this seems to be secretions. We'll confirm that on MRI, but you can see that particular difference in vascularity. So this is the vascular mass, and this is relatively looks like secretions. We'll see. The ethmoid septae are there, and then as we go further behind, we start seeing a little bit of erosion of the hard palate. Now clinically, there is no bulge on the hard palate, and there's no, actually you can't palpate this erosion. So we'll see what, intraoperatively see what is that. This is possibly near the posterior end of the hard palate, maybe a little closer to the greater palatine canal. Actually, the greater palatine canal is here. So we'll see whether we need to do anything over there, depending on where we find the tumor. It's not going very laterally. As you can see, it's at the sphenopalatine foramen, but not going into the pterygopalatine fossa. And then as we go posterior, the tumor becomes much smaller until you reach the nasopharynx. On the axials, it's more or less similar, but what I want you to see here in the axials is this. That's the normal nasolacrimal duct. And look what has happened here. So the nasolacrimal duct itself is involved. That is what we can see here. And if we look at the axials, this, you see this bony spur? Can you see this here? Can you hear me, Dvaipayan, or can I have someone from the moderators telling me whether they can hear me? You can hear me, right? Okay. So this spur, this bony spur, and a little bit of area of hyperostosis, not significant, is probably where the inverted papilloma is originating from. Now, if you look at the MRIs, in T2 you can see the clear differentiation of tumor from secretions. So ethmoids are full, more or less full of secretions. And if you look at this frontal, this is the frontal recess, that's the frontal sinus, completely filled with secretions. The tumor is not extending into the frontal sinus. We will open the frontal sinus at the end. There is a possibility of involvement, not possible, there is involvement of the ethmoids. But at the frontal recess area and into the frontal sinus, there are secretions. And as you look further, you can see this area. This is the mass, and this is probably area which will be mucosal edema and some amount of secretions, as you can see here, some amount of secretions there. But otherwise, the ethmoids are really full of secretions. And the sphenoid is relatively clear, except ipsilaterally there is a little bit of secretions. So basically, we are not dealing with an inverted papilloma going into the frontal sinus or the sphenoid sinus. It is limited to the entire maxi sinus, so it involves the other walls of the maxi besides the medial wall, and it originates more infero-medially and involves the nasolacrimal duct and possibly the hard palate. And if you look at on a stir coronal, I want to show this specifically. Are you focused on this? If you can see this, can you see this? This is that classical cerebriform pattern that one sees in inverted papillomas. You know, brain-like, like the gyra and sulcus of sulci of the brain. So this is that cerebriform pattern which is supposed to be pathognomic of inverted papilloma. Now I'll tell you what is the what is my plan of action, and how do I deal with vascular tumors which are friable. So we are talking about two types of vascular tumors, one which are firm and which are not friable and which don't come off easily. And we are talking about another type which is friable and which will debulk. So the concept is that to minimize blood loss, the initial part of the surgery should be quick and should be such that you minimize the blood loss till you've got the bulk of the tumor from the safe areas out so that bleeding decreases. So now if you look at this mass, first of all, in your mind you should be certain which are the areas which are safe and where there is no structure of importance that can be damaged. So if you look at this, you can see that all along the floor of the nose, all this, all this, all this, and all this, you can remove very safely even if there's a lot of bleeding going on. Okay, because you're staying away from the orbit, you're staying away even from the middle meatus. So if I show you a little more anteriorly, as long if this is the middle meatus, as long as I stay below this, and as long as I stay in this region, so we are talking about this entire region. So this can be removed very fast and very quickly so as to minimize blood loss. So then what is left with is in the middle meatus and in the sinuses, and as you go further behind, going towards the skull base. So the orbit and the skull base are the two areas that you avoid when you are doing quick debulking of the tumor. Now how do you debulk tumor? So there is a coblator, there's a microdebrider, and there are cold instruments like a Blakesley and a Lux. Now I find actually that a Blakesley and Lux works the fastest. So I usually begin, I don't use the coblator very much because I think it takes too long to do that. It takes much longer. That coablator keeps getting blocked, and you're losing blood at the time that you're trying to get that coablator to work. Besides the fact that all my patients can't afford a coablator wand, or there are many centers where coablators are not easily available as yet. So I use the microdebrider, and if I feel that the microdebrider is slowing me down, then I will use a Lux and a Blakesley. And the beginning of the surgery looks very barbaric. It looks, kya kar rahe hain kind of thing. But this is because you're working at speed and you're trying to debulk as much tumor as you can before you then pack the nose, wait for the bleeding to decrease, and then you go ahead with a more refined technique of actually identifying each structure, each bony spur, and removing tumor from those areas. Does that make sense? Yes, any questions on that? Any? I can't hear you. Yeah, now much better. Thank you. No, it's not a revision surgery. Yeah. Yes. No, actually there is erosion. If you want, I'll show you the CT scan again. There are multiple areas where are there. So I don't know whether it is pressure erosion or it's partial averaging. I mean, I don't think it's partial averaging. Let's put it that way. I'll get you this. Ither karta ilka. Look at this. So partial averaging will be in 1 or 2. But if you look at this, can you see this? This is intact. See these areas. See this area. See this area. So over here, between this and this, you would think maybe it's partial averaging. But if you look at the consecutive cuts, this one, this one, this one, it's actually whether the bone is actually very paper thin. It's more likely to be that there is a paper thin bone rather than actual through and through erosion, because clinically there is no erosion. Yes, yes. I can't hear very clearly, please. Yeah, now much better. Yeah. Yes. Yes, yes. Right. Because sometimes, with all the technology that we have, for example, I have everything. I have a debrider, I have a coablator, I have navigation, everything that I need I have. But sometimes, we need to understand that in some places, the tried and tested traditional methods also work and sometimes work better. Okay, so the tumor is on the left, but before I go to the left, let me just show you the right.
Ma'am,
Yes.
from Rajkot,
Yes.
just a basic question.
Yes.
Diagnose clinical and radiological.
Yes.
Do you actually take a biopsy also
Biopsy from where?
from the mass?
Oh, yes, but of course we take a biopsy, but I'll just come to that in a minute. I'll answer that question in a minute. We'll talk about when and how to take biopsies.
Because usually nasal masses we don't do it outside.
Yeah,
So
no, I'll explain that. Or I'll share my point of view. So I just want you to see that.
that is very important for the junior.
Yes, absolutely. So the only thing I want to show you in the right nasal cavity is you can see that the mass has come into the nasopharynx on the opposite side. Give me an elevator. And what I want to see is this adherent to the septum or is it separate? And can you see it's separate? I don't want to use a suction there. Can you see it's separate?
Yeah.
Okay, it's not adherent. So that's what I was looking for. Now I'll show you from the actual mass. So that's the mass. It's begun to bleed before we begin. So if I breathe on it, it's bleeding, but anyway. So you can see the multiple fronds. And there is something else that I want to show you. So that's the inferior turbinate here. It's also very polypoidal. The plan is, of course, to do a medial maxillectomy, a complete medial maxillectomy. So, and of course, with the nasolacrimal duct involved, of course, we'll be excising that part of the duct which is involved. So, an entire medial maxillectomy, that's the tumor. And give me an elevator. Thoda light badana. And those lights decrease. Okay, see, there is also normal polyps, which is a reaction to the blocking of the sinuses. So you see the difference between a polyp and an inverted papilloma. You can make out that very clearly. For the juniors, polyps are usually smooth, rounded, whereas an inverted papilloma will have fronds like this that you can see. So even if you see in the nasopharynx, you'll find that it will be bosculated or with multiple fronds, unlike an, say, antrochoanal polyp. So this is a polyp. That's the tumor. And you can see as you go further behind, it becomes a little smoother. Now, this is in the middle meatus. How do I know it's the middle meatus? Because if I go from above this polyp, suction, elevator. If I go from above this polyp, there, that's the axilla, or the, it's bulky, but this is where the middle turbinate can be palpated. I can feel the bone of the middle turbinate. Okay, so if that is where the middle turbinate is, then of course over here would be the middle meatus. Now about the biopsies. So you know what? It's, first of all, vascular masses, I never take biopsies in OPD. They're always done in the OT with an anesthetist, and if it's a very vascular mass, then under GA with a tube protecting the airway. Because it is disaster if the patient starts bleeding profusely and is under local anesthesia. Because at that time to give him anesthesia with an actively bleeding mass is really asking for trouble. So in that case, it's always better to never think, oh, biopsy lena hai. Because oh, biopsy lena can bring you to your knees. So therefore, very vascular masses which bleed just on touch, definitely under GA with a tube protecting the airway. And the other thing is where to take a biopsy. Actually, that is one of the key things to remember. See, if you look at this is all necrotic mass. There's no point taking a biopsy here. Because you'll get, you see this, see the differentiation between the tumor. So you need to take the biopsy from that smoother, deeper portion rather than from this. And the third thing about a biopsy is always keep, so when I'm taking biopsies, what I do is, if I'm going to take a biopsy from here, from deep over there, I will put in a nasal Vaseline pack inferiorly and keep. So what I will do is, I'll take a Vaseline pack and I'll insert it here in this area deep before I even touch the mass, so that there is no time lost after the biopsy in packing. So what you do is you put in the Vaseline pack here, and I use Vaseline packs when they're very vascular tumors. I don't use net cell, because the Vaseline sticks to that area and really stops that bleeding beautifully. So you put it there and then take the biopsy. If there is time, put a big rolled up Surgicel there, and on top of it put the pack. So that when you remove the pack, the tumor doesn't start bleeding again because it's covered with Surgicel. So as soon as you've done this, as soon as I've gone beyond this, taken a biopsy from here, then I'll just push that pack up. First put Surgicel and then just push that pack up. Does that answer the question?
Madam, still the question remains.
Yes.
Whether you should take a biopsy or not. Recently, this is so obvious with the radiology and the clinical appearance. And
Yeah.
come what may, once we can deal it, why to subject patient to
Correct.
the biopsy?
Absolutely, agreed. I'm not taking a biopsy in this patient. And ultimately it will become an excision biopsy. So,
The principle says most of the nasal vascular mass
debrider.
biopsy should not be taken if the radiology is good.
Absolutely. Absolutely. It's only when the radiology doesn't give you a answer, and also when your management may change depending on the histopathological diagnosis. For example, if you're not sure on radiology whether it's a benign or a malignant lesion, then in that case you definitely need to take a biopsy, because the extent of your surgery has to be correct at the first shot. You cannot say that I'll take out only the mass and then go in for redo in a malignancy. So therefore, when there's that doubt whether this is a benign lesion or a malignant lesion, and you're not sure from radiology, one way or the other, then definitely, even if it's a vascular mass, you would take a biopsy to establish whether it's malignant, in which case your management will be very different from, say, if it was a benign vascular mass. But otherwise, radiologically, if you can make out what this is, then I would definitely not go for a biopsy. Now, when we start debriding, the principle is to stay low, inferior and medially. Let's see how it goes. If I'm happy, I'll continue. If not, I'll just keep a Lux and Blakesley ready and Zade suction launch. Take this off. Yes, Samir. Hello. Not in this case. This is it's a very classical case. You can, the other thing you can do is, if you're not taking a biopsy for whatever reason, in a thing where you're thinking of malignancy, then definitely you'll do a frozen. Yeah? Manage what? We'll come to that. I'll show you. So you see, I've not taken any biopsy from here at all. I'm staying low and inferior. I'm not going above the level of the middle term. I'm in no hurry to take a biopsy, because so there's some pus in it also. Like I said, there are secretions. I'm going to go till I get a nice representative sample, which will be from the maxi sinus. So that's the part which I'm going to use for taking a biopsy, not this nasal part at all. You see, I'm staying low. Okay, I'm not going anywhere into the middle meatus with the debrider, because of course it's not bleeding so badly. But otherwise what happens, it bleeds so badly that you have no vision. And if you don't have any vision, there's no point of going into the middle meatus without vision. So I'm going and looking for my first landmark. Okay. Yes, yes.
Basically, as far as the biopsy is concerned, the message to the juniors and the juniors, all major masses try to rely more on radiology than going for pre-op biopsy.
Yes, agree.
As Roger section Samir has said,
Yes.
that depends as how we progress. Suppose if the diagnosis seems to be quite clear and we can take out the mass and go for it, probably there is no place for frozen section, because frozen section is not available at all the sections. So we cannot rely
Yeah.
more on that.
I agree absolutely with you. In fact, one principle that I apply is, if my management is going to change because the biopsy report is going to change, then I will go for a biopsy. Otherwise, I'll do an excision biopsy. For example, if I want to know how to treat the lamina papyracea, how to treat the orbital periosteum, then in those cases, I will definitely do a biopsy. Whether I feel that I have to remove part of the orbital periosteum with the mass, whether I can just shave it off the orbital periosteum, all that will depend on whether this is a benign or malignant lesion. And there, when you can't get these answers, that's when you will. Okay, now I'll talk a little later. Take a large section. Now what I'm going to do is, I'm going to actually show you the other way to do it, which is with a Blakesley and give me a elevator, broad elevator. Broad elevator. I'm just lateralizing the inferior turbinate a little. Let's see whether good access is available. Okay. It your suction. Huh? It. Huh? Give me a Blakesley. Keep moving it around. वरती ठेव सक्शन. काय झालं? वरती ठेव. दूसरा Blakesley there which will hold. Suction. Suction. See how I'm bulking large masses, okay, large pieces of mass. And see how I'm keeping low. Making sure I don't go into anywhere near the orbit or the brain. Suck, suck. Give me that. Now I need a little more vision, so I'll use the debrider. The suction has come off. Give me the debrider. Always make sure you see the tip of the debrider when you're operating. Never operate without a tip of the debrider being seen. Okay, so as I went posteriorly, I was finding access for that lux a little difficult. So I was not sure what exactly that lux was catching. That's why I shifted again to a debrider because it's giving me vision while I'm cutting. You can see here that the inferior turbinate is involved in the mass. Can you see this? The inferior turbinate is involved. There. Give me a pack and a suction. मोठं जाड suction लावायला. Okay, so what we are finding is that the inferior turbinate itself is involved. Can you see this? Yes? Yes? I can't hear. Are you able to see it? Okay, so now what I'm going to do is, because the inferior turbinate is actually involved, I'm going to remove at least the posterior part first, so that I get more space. Give me a turbinectomy scissors. What were you saying? Yeah, give me a pack. Open it. Blakesley. Not this Blakesley, proper Blakesley. So I'm going to pack a little while. दूसरा पैक्स तैयार रखो. Keep a turbinectomy scissors ready. दाखवा लिहून. Yes, I can hear you. Well, multiple possibilities. It can be a hemangioma, it can be a pericytoma, it can be angiomatous polyp of the septum, it can be rhinosporidiosis, it could be esthesioneuroblastoma, it could be a squamous cell carcinoma. Yes. Can it be? Well, that we'll know only on histopathology. That's so. If it is not in case of inverted papilloma, and clinically we don't feel. I've done a DNA on this patient, a diagnostic nasal endoscopy before the surgery, and it looked very much like an inverted papilloma. So therefore, I've not done a biopsy. But if I had any doubts, then I would go for a biopsy. Give me a flush. Suction gala. I'm not able to see what. Okay, elevator. So I'm just lifting up that inferior turbinate a little, because you see it's not giving me enough access. And as you can see, it's clearly involved. It's only this anterior tip which is not involved. Others, everything is involved. Suction, turbinectomy scissors. So for the time being, I'm leaving this anterior tip, and I'm removing the entire inferior turbinate. Not entire, most of it. It's like debulking. Yes?
Can you, in this case, can you go for the approach of modified Dangler?
On the head. Let us see, no? We'll see depending on what it looks like. Clean. Lux. See, so early in the surgery, I really can't tell you. We'll see as we go along whether we are able to get access or not. Yeah. Oh, bus. Clean. Clean. Give me vision. Clean. All this is biopsy. Huh? So you see, I've taken all the representative portion as biopsy. You know, one of the greatest skills or the greatest contributions that a radiologist can give a surgeon is to indicate which area to take a biopsy from in a mass. There have been umpteen number of times that the patient has come either, done by us or done outside, where the biopsy has been negative. And then I've gone and spoken to one of my radiologists, senior radiology colleagues, and actually sat on a console with them And then they tell me, okay, Renuka, try and take a biopsy from here. And then that biopsy comes positive. Okay, give me a debrider now. So you see, I'm mixing things, okay? Give me the debrider always in the correct way, please. No, pointing upwards. So I'm partially using debrider, partially using thing, depending on. So at any point where I feel that I can't see the tip of the debrider, where's the suction? Keep it ready for when he's flushing. Okay, don't flush just now. So this is the involved inferior turbinate that I'm completely removing. And the posterior choana is gradually coming into view. So just remember, I'm not taken out the entire inferior turbinate as yet. This is that part of inferior turbinate which I have removed where so I can have better access and vision. And I'm looking for my first landmark. And that landmark is coming, give me a straight suction. And that landmark is coming into view now. Keep a pack ready. Yes, no, nasal pack. Can you see the eustachian tube? Yes? Okay, and that's the roof of the posterior choana. So that's the first landmark I'm looking for because that will give me depth. So, if I'm operating anywhere here, in any place over here, in this region, I need to know how deep I am. And if I need to know how deep I am, I need to use the nasopharynx as a roof of the choana, as a landmark. Okay. Now the next thing. So you see, I've cleared up this area. This is not the end of this area. This area we're going to come back to again. But now that I have this this access one, and the second thing that I have is the landmark of the choana, then I'm going to now start going in and doing the rest of the surgery. So first, before that, I'm going to pack for some time. Wait a little while for that bleeding to become less. ऊपर उठा के रखो ऐसा. So you see, in the initial part of the surgery, the vision is not absolutely perfect. So you need to be very certain whether you're using a Lux or a Blakesley or a debrider, that you're very certain that you're taking out tissue from that safe area that I showed you. If you're not in that area, don't blindly remove any tissue. And in fact, always those areas you deal with after the bulk of the tumor in the nasal cavity is out, when you have better vision. Pardon?
There must be some changes, malignant transformation, what we call transitional cell carcinoma.
Yes. Well, I think on texture in an inverted papilloma, it's difficult to make out. Because inverted papilloma itself, even the benign tumor is very, very friable and very easily. See what happens in malignancies, they become more friable because the cohesiveness between the cells decreases in malignancy. So the tumor becomes more friable. So you may have a benign tumor which will be less friable, and where the malignant change has taken place, it may be more friable. But in inverted papilloma itself is so friable that to differentiate, demarcate between the benign and the malignant area becomes difficult. But in certain tumors, you will find that and of course, if it's a very firm tumor, like if the inverted papilloma benign area is quite firm, and then you go to an area which suddenly appears much less firm, which debrides much more easily. then you can say that area could be malignant. This is now seeing in the right nostril, and you can see that the mass which was in the nasopharynx on this side has also gone. And the septum is absolutely intact, the mucosa, which means that there was no adherence to that. Okay. Now we are not going to go back into the right nasal cavity at all. We'll just be dealing with the left. Any questions? Okay, I'm going to wait a few more minutes for the pack to work. Yes? So there are, the newer one is Kennedy, and the older one is Krauss. So the Kennedy one is involvement of the nasal cavity and the medial wall of the maxillary sinus. That's A. B is involvement of the other walls of the maxillary sinus and the ethmoids. And the sphenoid, sorry, A is nasal cavity, medial wall of the maxillary sinus and the ethmoids. B is involvement of the other walls of the maxillary sinus and the frontal and sphenoid. And C is when it involves extraparanasal. And Krauss's classification actually is quite similar. Only thing, T4 is extraparanasal and T1 is only in the nasal cavity, and T2 is ethmoid and ethmoid sinus and maxilla, and T3 is involving the frontal and sphenoid. So from only the nasal cavity to extra paranasal is T1 to T4, and between the two is when there's maxilla and ethmoid involved, T2, and when frontal and sphenoid is involved, T3. That's extra paranasal sinus. There's no separate classification for the orbit. Okay, so now we have this much under control. Now the fact is that the tumor is all in the maxillary sinus here, you can see it. But what I want to do is, that's the axilla of the middle turbinate, which looks normal in the sense the mucosa looks normal, but it's very polypoidal. And this is the area of the ethmoid. Now before I go into the maxillary sinus and again the bleeding starts, I want to actually finish this part in the ethmoid. Okay, so that I can see the lamina papyracea. Because I want to use that as a second landmark. Blakesley? Yes. And once I go into the maxillary sinus and all the bleeding starts again, I won't be able to see it that well. So while I've got that under control, I'm actually going to clear this area first.
Hello.
Yes.
Yeah, I'm Dr. Bilal from Srinagar.
Yes,
As
yes.
as you mentioned rightly, this is the surgery of landmarks.
Yes.
As you put the back, we are able to get various landmarks.
Yes.
Will you like to, for reduction of the, to reduce the bleeding, would you
Yeah.
like to take any precautions free of or take the help from the anesthetist to reduce the bleeding?
Yes.
So that you are not comfortable during surgery.
Yeah, so actually that is what I wanted to do, and then somehow another question came up, and I want to introduce you to our anesthesia team. Our professor of anesthesia and the head of the anesthesia and ophthalmology units is Dr. Kanchan Rupavate. Dr. Kanchan Rupavate and I go back many, many years, and I'm going to ask you to give a special round of applause to the entire anesthesia team. The other associate professor is Dr. Neelam, and there's an entire team of. What I want is that, this is, see, we are surgeons and we like to operate and demonstrate, but the anesthetists are the real heroes, because they're giving me a field which, so that's the lamina papyracea. They're giving me a field where I can work, and they've especially come on our request for Sunday. They work our Sion Hospital emergencies and all are very, very heavy. So they have a very heavy week. So to sacrifice a Sunday and come is a very big deal. So I'd like to thank all of them. And when the next time I pack, I'm going to ask her, Kanchan, to give you, Dr. Kanchan, to give you what they do to decrease bleeding. So we'll come to that when the next time we pack. Can you see the lamina? Can you see the?
Yeah, we can see the line.
Okay, so that's the landmark we have taken. Okay. Now, as I remove part from the maxillary sinus, I will also remove this so I can see it better. What I'm going to do now is remove the posterior ethmoids as well as this, open up the sphenoid. Yeah, what were you saying?
So you are,
Everything they'll tell you. Everything they'll tell you. In one go. What we have done as surgeons is given IV antibiotics. The patient is from out of town, so when he came, how many days have we managed antibiotics for him? That's what I was saying, that the sphenoids are full of secretion, the ethmoids are full of secretions. How many days has he been with us? 5 days. So 5 days of IV antibiotics we've given him.
sorry to interrupt you, all our junior colleagues, can you demonstrate how you went inside the, what landmark you used
Okay.
into the sphenoid?
Okay, yeah, I should have mentioned that. So what you do is, as you open anterior and posterior ethmoids, you will start gradually, first see the lamina papyracea, then you start going gradually inferior and medial in the middle meatus, not like this inferior medial, but in the middle meatus inferior medially. I am not sure yet this is the sphenoid. I think this is still an ethmoid cell. Let's see. So, because other landmarks like the superior turbinate, etc., are not seen because of. So you stay. This is the lateral approach. So at the lamina papyracea, you go inferior medially. The other approach is, of course, through this is the superior turbinate. Probably. Give me an elevator. Yeah, and that when you lateralize here, the superior turbinate, and you go through here, that is where the medial approach to the sphenoid is. This is where you'd go medially to the sphenoid. I'm not going to go there because I don't want to create too many raw areas. I don't want to disturb virgin areas. Give me a punch. Keep it ready quickly. And clean it immediately, okay? Because it's filling up with blood.
Basically, Dr. Renuka, you follow the tumor, and as and up to what place it is, you go up to that. And clear there, no need to open the pressure.
No need to open the. Yeah, at least definitely don't do mucosal trauma where there's not needed.
Right.
Definitely not.
And sometimes if this part, ethmoid part is bleeding very much, then you crack it and
Yes.
flush, isn't it?
Yeah, so you're seeing that, keep flushes ready. You're seeing as I'm doing it that, so the sphenoid is not involved. I've used the suction to widen that area. And let me see. Only when it gets hazy.
This looks like posterior third only,
I'll let you know. Give me a straight upward Blakesley. Card. Card na. I'll let you know. Give me a minute. See this is the sphenoid, okay, because I can see the lateral wall. Let me just see a little bit inferiorly where the choana is. No, I think there is another. Give me an elevator. So, see, because the mass is there, the secretions, I couldn't make out exactly. So this, where I've gone in, is the normal sphenoid ostium. Okay? Here, okay? So now we need to connect the two. yes, medially is always best in the sense if you are lost or more than lost, it's not lost. It's when you want to reconfirm. Okay, so now I'll show you here. See, that's the sphenoid there. Now the reason why you feel that this could be the sphenoid is because it's very large. Okay, so it's like an onodi cell with a flush it, no? It's like a large onodi cell. Don't, I'll manage. It's like a large onodi cell, and this is where the sphenoid is. So the sphenoid is much smaller. Give me an upward, Blakesley. Okay, I want to show you something. I'll thoda external camera dena. My hands. Hands are seen. So you see this, how I hold it. So the suction in one hand and the Blakesley in the other hand. Can you see that? So what I do is, when I'm external camera hi rakhna, when I'm sucking in an area which is bleeding, I will keep the suction and Blakesley both in my hand, and give me a straight Blakesley. And then I'll just drop the suction and go in with the Blakesley. I'll show you again. Keep flush ready. So, suction. That's the sphenoid. It's clear. Can you see it's clean? Okay. And this is the posteriormost ethmoid, which is very widened. Can you see? You can see the impression of the, I can't remove the mucosa, but can you see the impression of where the optic nerve would be? Let me try and. Okay. Yeah, it will be because it's a mass. Can you see this? Give me a elevator.
Madam, if you give warm saline wash,
Yes,
it's clear.
yeah, I'm keeping warm saline washes ready. This is the optic nerve here. Flush. Keep flushing. Yeah, intermittently. Keep flushing intermittently. See, this area is where the optic nerve will be. Here. That's the posteriormost ethmoid cell, therefore that's an onody. And that is the sphenoid down there. Flush. Flush. Flush the whole thing, yeah. Yeah, what do you say? Wait, let me pack now, and then we'll wait for the bleeding to stop. By that time, I'll show you on the CT scan. But on the CT scan, what you can see is only a lot of, I'll show you. So the reason why the posterior ethmoid looked like the spheno is because it was so widened that I could see, in fact, you can even see a little bit of bulge of the sella in that posterior ethmoid. So I'm packing in layers, okay? First down, then up, then down. So I start down here, then gradually go up. Start down again. And then gradually go up.
So basically you are layering it to put more pressure.
Yes, yes. So what you're talking about, whether the medial approach is best, actually in an area which is relatively, suppose you're doing it for polyps, ethmoidal polyps, or you're doing it for sinusitis, either approach is good. Lateral. But when you're doing it in a case where there's a tumor where there's distortion of anatomy, and you open into an area which you think is the sphenoid, then you're not sure, then you will confirm medially. It's not necessary in a case of sinusitis that you need to always confirm medially.
Yes, sir. We were talking about this case because that's how the
Yeah, so let me show you. Let me show you. See, ये दिखाना. Yeah, I'll show you in bony and in thing, but you can see it here well. That's why I'm showing you. Can you see that? That's the sphenoid on the right side. It also has an onode, and this is the sphenoid on the left. So the sphenoid itself is very small. That's the onode. That's the onode, and that's the small sphenoid. If you want to see it on bony windows, can you see this? That's the sphenoid, and that's the onode. This is the sphenoid on the right side, and that's the onode. And you see what I was saying, that the impression of the optic nerve will be here, where I was showing you on the, for example, look at this. Can you see this? This is the impression of the optic nerve. So if you see anteriorly, the onode is larger and the sphenoid is very small. Over here also the onode is larger and the sphenoid is much smaller. If you're going into a small sphenoid like this, then suppose there's a lesion in the sphenoid sinus that you want to deal with, and the sphenoid is small, then in that case a medial approach is always better. And also not just a medial approach, but staying very close to the septum. That means just above the rostrum, and not very high up, just about a half a centimeter above the rostrum, so that you will always enter even a very small sphenoid. Keep lots of warm saline ready. Okay, I'm not, we are not doing a FES here, so I'm not going to go in and show you all the widening of normal steps of FES. I'm just open the sphenoid. At the end of the surgery, I will neaten it up. Staff, zara bolu na kamade. So I'm not going to show you normal steps of FES now. I'm going to show you what we're doing to remove this mass. At the end of the surgery, I'll neaten up everything. Widen up the septa between the posterior ethmoids, sphenoids, etc., everything. But at the moment, we are not going to do that. We are just going to deal with the mass. Okay, so now we have the lamina papricia. We have the roof of the choana. We've trimmed part of the inferior turbinate, so we have access. Now I'm going to show you what I do. Give me a curved maxi suction without a suction attached to it. And keep a curved debrider ready. And an upward Blakesley. Keep warm saline washes also ready. Okay, give me a suction. Suction. So once again, what we saw on the CT scan, that's the roof of the choana. That's the sphenoid. And that's the posteriormost ethmoid over there. Posteriormost ethmoid, and there where I showed you that the optic nerve would be here, in this area. The septum between these two I will remove later on. So now let's get going with what we are supposed to be doing. So what I do is, in these, especially in maxi sinus, especially where there may be, now in this case there's no suspicion of erosion of the maxilla, but if there's a suspicion of erosion of the roof of the maxilla or the floor of the orbit or the lamina papyracea, I never try to enter the maxi sinus through the normal ostium over here. As you can see, the middle turbinate is also trimmed because it was all involved. Actually, it's not trimmed with the mass, it has come out because the middle turbinate itself was completely involved in the mass. So it's not that I've got like the inferior turbinate was seen separately, the middle turbinate has not been seen separately. It has actually been completely involved in the mass. So now that you don't have the middle meatus, the middle turbinate as a landmark, except the axilla of the middle turbinate is better seen, always open the maxi sinus above the inferior turbinate. That's the safest area to open it. And then of course we're going to do a medial maxi sinus normally. So this is what I do. I am opening the maxi sinus above the inferior turbinate. Okay, then the next thing we do is we widen that area. Give me a suction. Give me a debrider. Now you can see the rest of the inferior turbinate, okay? All completely involved in the mass. Give me the debrider. No, a straight one first. Curve suction. Not this one, this one. Attach this one. Turn it towards you. Yeah. Always turn the suction infero-medially, okay? Not just towards the sinus, but slightly inferiorly. So I'm actually outrolling that entire inferior turbinate. Debrider. Flush it, na? Stop. When the vision comes, you stop. Stop. So we are now removing the part of the medial wall of the maxi sinus. You'll never get in a vascular mass, you'll never get a perfectly clear field. Only thing is you should be absolutely certain where you're operating and what you're doing and whether there's an important structure nearby. But if you keep waiting for a clear field, give me a turbinectomy scissors. So this is the rest of the inferior turbinate that I am resecting partially. Suction. Blakesley. So this is part of the This is part of the inferior terminate. As you can see, it's completely involved. Okay, keep pack ready. Debrider. Flush. When you see that it's blocked, not now, when it the vision goes. Okay. Okay. Give me an upward Blakesley. So I'm going to debulk a little more and then we'll pack. Flush that, not then. Flush. Suction put. So this is what I'm debulking out of the maxi sinus. Give me a suction. Yeah. Take. Yeah, she'll talk about it. Just a minute. Debrider. Flush. Suction. So you see that the bulk of the tumor is now out. That the bulk of the tumor is now out. And now we'll start doing the finer work. So now before I go on to that, I'm going to put a pack and I'm going to hand over to Dr. Kanchan Rupvate. There's a little more which we need to remove before we can pack and then go for the finer work. Give me an upward Blakesley. So all this, take that out of the way. All this which is along the roof, तुम लोग तैयार नहीं रख रहे हो फ्लश. All this along the roof we'll remove. Now this is what I meant when I said that there will be normal mucosa near the roof. Can you see this? This is normal mucosa. Is it seen? Yeah. We are going to come to that. At the moment, I've just opened the maxi sinus. I'm saying that in that MRI also we saw that there is normal mucosa above. And that, so this is actually normal mucosa, but in the interest of the fact that there may be tumor niduses in it. Flush? Yeah, you finally got your act together. Keep flush ready. What Blixley? तुम इधर आओ फ्लश कर. Okay, now we'll pack because most of the bulk is out. Flush in my hand. Yeah, so it takes some time for this have to happen, and so you keep, so you don't, you can't just do blindly when there's bleeding. You have to be certain that the areas that you're tackling are giving you one landmarks, and second that you're not going into an area without vision which is of some sort of danger. So those are the two things. You're looking for landmarks. Yes, yes, you can see it clearly. You can see there's a lot more to be done. At the moment, I'm just thinking now I'll just remove a little more of this and keep a cautery ballpoint ready. When I do that, no possibility of the sphenopalatine artery, keep a cautery ready. Cautery, just give it to me in the correct way. So this is the junction of the posterior wall of the maxilla and the ethmoids, where the palatine bone is, because that area you can sometimes there, as I said. Are you ready? Okay, keep a suction inside. Where's the cautery pad? Press. Be careful. Okay. So you should anticipate that and know that that will happen and be ready. You need only a monopolar. You don't need a bipolar. Because anything which is not near the orbit or the brain, you can use a monopolar. Give me the cautery again.
We have found the coblator used in
Touch. Yeah, you can use a coblator as well, yes. But as you can see, even a monopolar, see how it works. It works very well. Actually, here it doesn't matter because you're not dealing with any structure of importance. Whether it's not like you're operating on the vocal cords here. If it cauterizes a little more of 2 or 3 millimeters of mucosa on either side, it really doesn't matter. Because ultimately, it's not going to have any functional deficit. Okay, now there's actually one thing that I do in medial maxillectomies, which I can't do. I fashion a mucosal flap. But in this case, it's gone all the way up to the floor of the nasal cavity. So there's no question of creating that mucosal flap. Maybe later on we'll talk a little bit about it. Give me a pack. And is Dr. Kanchan there? Madam na zara ek mic down.
Hello, good morning all doctors. I am anesthetist. Today's case we are doing, and this patient needs Hello, good morning all doctors. Good morning. Yeah, we are giving anesthesia to this case.
Take it
today,
off, take it
and
off, take it off.
Surgery
Take the picture.
requires hypotensive anesthesia. So I heard the questions were asked, what we have done pre-op. So this patient is a known diabetic. We have controlled his blood sugar, and pre-op we have given steroids to reduce the edema and inflammatory changes and to reduce the blood loss. 2 milligram per kg IV injection hydrocortisone. And we have we have induced the anesthesia with injection propofol, fentanyl. We have given 10 to 15 degrees head up so that the venous drainage is improved. And during the intra-op, we have given, actually pre-op we have given injection tranexamic acid to reduce the capillary bleeding also in a dose of 10 milligram per kg IV, that we have started pre-op only. 500 milligram we added in 1 pint, and that has gone over a period of half an hour when patty insertion was going on. So actually this is a vascular tumor, so even though we are taking care of the systolic blood pressure, it has bled a little bit. So actually we have managed the blood pressure and heart rate product, which is usually should be less than 7,200. So systolic blood pressure into heart rate, that should be less than 7,200, so which we are maintaining. And we can see on the multipara monitor,
उधर स्क्रीन को देखने का
at
फॉग
present
हो
the
गया तो
patient's
फ्लश
blood
फॉग हो गया
pressure
तो फ्लश
systolic
तू
is
सक्शन
88
ठेव आतमध्ये
by
तो मी फ्लश केला आणि
60.
तिकडे सक्शन असेल तर
Actually,
काय
we are
दिसणार
controlling
तर
the,
द
we are
मोमेंट यू
taking
फ्लश यू सक
into consideration the mean arterial pressure. So
And
we are
don't
maintaining
flash
MAP
when
mean
I can
arterial
see
pressure
everything.
below 60 or up to
moment
60.
the thing clears
And
up
heart rate
and
is
you put the
86,
suction in.
ATCO2 is 34. So we are controlling the end-tidal CO2, blood pressure and heart rate. And at the same time we are giving the tranexamic acid infusion as well as injection dexmedetomidine infusion. So this is a new alpha-2 receptor agonist. So it controls the blood pressure and heart rate. It is a specific selective alpha-2 agonist, and by binding to the presynaptic adrenoreceptors, it inhibits the release of norepinephrine, therefore terminates the propagation of pain signals, and also it inhibits the sympathetic activity, decreases the blood pressure and heart rate. So we are maintaining the patient using oxygen nitrous 50-50 with dexmedetomidine infusion and inhalational agent desflurane, controlling the heart rate, blood pressure and maintaining the end-tidal CO2, which is between 35 to 40 millimeter of mercury. We are keeping the range, and this is how we are maintaining the hypotensive anesthesia. So, any questions regarding the anesthesia? As far as anesthesia is concerned from the audience, they are welcome. Thank you very much for giving me the opportunity.
Okay.
Yes, ma'am. Hello.
Hello. Yes, sir.
Anesthetist, ma'am. Right now the pulse rate is 86 to 90.
Right.
It would be better if we keep it to 60, 65.
Yes, actually at present patient has bled a little bit, 400, 500. So there is actually compensatory tachycardia. We have given the colloid and we'll be giving the blood. So basically that heart rate is because of compensatory tachycardia because of the blood loss. Otherwise it was, we were maintaining between 70, less than 70. So basically we were seeing the blood pressure and heart rate product which was less than 7,200. Yeah, thank you.
Suction.
Hello.
Yes. So I've,
Hello, ma'am.
yeah, so give me a curve suction.
I'm Dr. Ashok from Dharwad.
Yes, yes.
We want to know which is the commonest area of injury?
Of what injury?
Commonest
area of origin of the inverted papilloma?
About usually at the inferior or inferior lateral junction.
And what is the chances of recurrence in inverted papilloma cases?
If you've done a good job and you've drilled the bone from where it is coming, then there's, so I'm looking at the maxillary sinus now. That's the zygomatic recess.
Yeah.
And you can see that the entire mass is out. It's only normal mucosa. Can you see it?
Yes.
That's the zygomatic recess. That's the floor.
Floor, there was some sort of erosion.
Yeah, so that's what I was also thinking. That's why I said I'm not sure whether it is because of pressure erosion. So let's go back again. That's the, so give me a straight suction first. Okay, let's go back. There's a little bit of a query, this is a bit of tumor, I think. Okay. There's a little bit of tumor that I think, and there's also, an inclusion cyst over there.
Are you with 0 degree or angled scope?
Angled. 70-degree scope. So that's the posterior lateral wall, posterior wall of the maxilla. That is the zygomatic recess. That is going to the lateral wall of the maxillary sinus. This is a pus cyst. Occasionally a tooth root looks like that, okay? I don't think this is a tooth root. There's no tooth root in the maxilla, but just for the juniors, something which looks like a pus, this is actually an inclusion cyst. But sometimes a tooth root can look like that. And this is the floor of the maxilla. Can you see that? Yes or no?
Yes.
Okay. So all of it is clear. So that erosion of the hard palate is probably just pressure erosion. Because like I said, clinically it didn't look like this. Okay, so that's the entire maxillary sinus.
There is no fistula in the cavity.
No. So there's that little bit of mass I'm going to remove, and then we are going to, so this is actually still part of the inverted papilloma. That is, that is normal mucosa. This is normal mucosa, and so it's the junction of the tumor and the thing, but I'm going to remove that mucosa, which is at the junction. The part in the floor and the maxillary sinus, I'll decide what to do. I've not yet made up my mind. Okay? Give me a suction, straight suction. Let's take out the remaining pack. So another thing about removing packs is, just a minute, is that, when you remove the pack, you don't have to remove the whole thing necessarily. You will only remove that part which you need for operating in that area or for vision of that area. The rest of the pack you may cut and leave behind and take out. So you can remove the pack piecemeal if you want. Cut it. So just because you put in one pack doesn't mean the whole thing has to come out in one. Only thing is you have to make sure that your sister knows exactly how many pieces of pack. So you don't by mistake leave behind a piece of pack. So that's very important. Give me a warm saline flush. External camera then. Again a flush. Suction. External cannula lagaya? Okay, so I'm going to show you how exactly it is that you can see the entire maxillary sinus very clearly. So if you, first of all, you need a 70-degree telescope. Then the second thing you do is you go all the way up to the posterior wall of the maxillary sinus.
Audio visual can be heard, EIP?
So you go all the way up to the posterior wall of the maxillary sinus, and then you just rotate the cable like that to look inside. So I'll do it one more time and show you. Go here and then just rotate the cable like this to see the entire maxillary sinus. So I've not turned the camera, I'm just turning the cable. Okay, give me a straight. Now we need to see what is happening near the nasolacrimal duct area. So we've seen that the hard palate is not involved. Also, I have not yet found any bony projection which tells me that anteriorly or anywhere where, I think we can take out that remaining pack, it might get left behind otherwise. It's not serving any purpose now. Give me a flush. Okay. Give me an upward Blakeslee. This is that bit of tumor that I was saying. I'll go back with the 17 and make sure that I've removed. Actually, I should have removed it then. We'll go back and remove it properly. Suction. Curve suction. Yeah, that's orbital fat. You're right. So it was, no, that was tumor. What I removed was tumor. Definitely. You know what this is? This is that area which was eroded. That was area which was eroded. The one that I showed you on axial, that's the area. Okay, this is going to be approximately just a little posterior to where the lacrimal sac would be. This is where the lacrimal sac would be, it is there. So what I removed was tumor, not fat. Do you have that piece still? Can you see this is, yeah, can you see this? This is what I removed. Okay? You can see that typical, the dotted appearance which you see in inverted papilloma, these are the central vessels in that each rete peg. Can you see that? Yes. Those dots. So this is typical appearance of inverted papilloma. In the front, you will see these vessels, single vessel in between. So you can see that what I removed was actual tumor. And beyond that, that is the area which was eroded, probably, because I have not removed any bone from that area. Don't wipe while my scope is inside, okay? There, so I have not removed any bone there. The moment I remove that mass, that bit of orbital fat has come out. So it's not an iatrogenic break there. It was already there. Okay, when I removed that mass, it has come out. Okay. Now we need to, yes. Yeah, so this is what I mean, that in this case, this is that in cases like this where you're not sure what to do now, that's when you need a biopsy beforehand. Now, as you can see, that fat is definitely not infiltrated in any way. It's absolutely normal fat. But if you cannot make up your mind between whether this is a benign tumor or a malignant tumor, then you need a biopsy beforehand, because if you have this kind of erosion and you're not sure whether the fat is infiltrated or not, whether the orbital periosteum is involved, then whether to remove only the lamina papyraceae or to remove the orbital periosteum or to also remove the fat, that decision will be taken depending on that biopsy. Therefore, in those cases, you will definitely do a biopsy. In this case, you can see that it's absolutely normal fat. There's no infiltration at all. Okay, now what we'll do is, now we'll go for looking for the nasolacrimal duct and whether it's actually involved. Okay, so give me a cautery ballpoint. I'm going to take off now the anterior head of the inferior turbinate. As you saw now, I've removed the inferior turbinate bit by bit. Why? Because otherwise the inferior turbinate can bleed quite a lot. Cautery. And then it will keep fogging your scope. Bas. Blixley. Give me a flush. I'm sorry, I didn't hear. Yes. Yes. So now what I want to show you is, I'm not sure, I'll just check a little bit more. Give me a patty and a smaller suction. Keep this, check this. Small suction. Keep infiltration ready. So there is this mass over here. I don't know whether it's actually blocking the nasolacrimal duct, or it's, actually infiltrating, or it's just blocking. So I'm going to remove this first and then look at what the mucosa looks like. Any questions on this? Can you see this is mass? So I'm going to remove this first and then look at what the rest of the mucosa looks like and then decide further. Give me a upward Blakesley. So whether it's the papilloma just involving the yeah. Clean. Now, see, I want you to see the difference in the feel. The first time that I used the Blakesley, it peeled off very easily. That's what tumor feels. And now you see how much difficult it is to peel this off? Because this is normal mucosa. So the feel you will get with normal mucosa, when you're trying to take it off, it will not peel off easily. Whereas the tumor will peel off easily. So I'm plucking it off, but this is the interface with the normal mucosa. Okay. Yeah. Can you see the movement? Move now. Okay, so can you see that One more time. Okay, keep doing that. See, I told you, no, it's very close to the nasolacrimal duct, that fat. Can you see when she's moving there? You can see that. Okay, give me a debrider. Suction. Suction. Yeah, I've gone to the bone. What I'm going to do is, give me a. Okay, give me a sickle knife. Taking out a little bit of this mucosa, and I'm going to open up that area. Yes?
Can we do osteotomy and dissect the nasolateral duct and we can cut optically the high half?
That's what I'm going to do. I'm going to dissect from the, I'm actually going to dissect from the sac down. So I'm going to dissect from the sac down. Give me a punch.
Now I have a question. I am Dr. Prof now.
Yes?
Was this patient had any symptoms of nasolacrimal duct obstruction?
Yes. He had epiphora since actually just a week.
Yes, madam.
Just a week.
There was an indication.
Yes.
Thank you.
Suction. Wait. Okay, give me a punch. So, you know, when you want to know how much is involved, you need to open up near the normal duct. Okay, so that's why I've opened a little higher. So that, see, that's the duct. Okay, I've opened up a little, give me a patty. So then I can see the junction of the normal duct and the infiltrated duct. Punch.
Dr. Bradoo,
Yes.
here is some question from Raji.
Yes.
is the data reference of inverted circular?
Well, it see the duct is involved. Okay, it seems like it's involved, doesn't look normal.
We'd rather be safer than.
Yeah, so that's why I said I open. See, now this is normal duct. Can you see that?
Yes.
Above is normal, this is infiltrated. So if I open from below, I keep going higher and higher. But if I open from above, I can see the exact distinction between normal and infiltrated duct. Can you see that?
But you would still be giving the safety margin, right?
Yeah, yeah, yeah. Punch. Smaller suction. Give me a ballpoint.
So you are going to dissect this out and.
Yeah, can you see? Yeah, can you see that? Okay, this lower part I'm going to just debride out, but I want you to see the junction of the infiltrated part. So actually, no, it's almost up to the sac that it is infiltrated. So that's the duct. Can you see the entire duct?
Yes, we can see the back.
Yeah. So that's the duct. Give me a ballpoint again, or give me a sickle. Flush. Give me a sickle. Suction. Ballpoint. Not this one. Find that other one. Give me a patty. Suction. Keep a drill ready, okay? Ballpoint. Give me a turbinectomy scissors. Suction. I'm I'm transecting where it is absolutely normal, okay? And a sharp cut and oblique so that it stays open. Sometimes, let's see at the end of the surgery, sometimes no, if I'm not very happy with uh, with the fact that there's a lot of raw area around it, then I will actually open the sac also. All this is going to come out now. Give me a debrider. This is all that infiltrated duct. And then I'm going to drill this bone. So I'm trimming up the last remnants of the inferior turbinate. Give me a suction and give me a saline flush. Saline flush. You have 2 syringes? Yes. Then use them. So, if you can see, can you see this bone? It looks rougher. Yeah. Yeah, see, look at this bone. Can you see how it is? Wait. Can you see how this bone looks normal? And look at this. I am going to. You know what? I was looking whether there is any other point of attachment before I spoke about that. Because usually they tend to originate more inferolaterally. And that is what I thought on the CT also. But you can see it's absolutely normal mucosa. So there's no mass over there at all. So the question of it originating from there was not there at all. Because if you have normal mucosa, then the mass can't be originating from bone under normal mucosa. But the mucosa would have been infiltrated. And as you can see, it's absolutely normal mucosa. So I was a little concerned about where that bony attachment would be. And then you see here, you can see this very clearly that actually the bone changes in character. This is normal bone here. Flush. Yeah. This is normal bone here, and you see this. Can you see this? This is roughened bone over here. And then again you're getting normal bone here. Okay? Any questions, any doubts about that? See, this is all normal bone around it. And this is the area which is rough. So we'll drill out that, and I'll also be drilling this down right to the floor. It's not still the end of the surgery because I'm drilling out that bone, but what I'm going to do now is actually finish all those, removing all the remaining cells, etc. Annaga? Yeah, I will do. Just a minute. I'll finish the nasal part first completely and then check with syringing. This is the area that I want to drill out. The rest of the bone is absolutely normal bone. Where's the drill? कुठे केलं change? Suction. लगा देना वापस उसको लेकर. Syringing I'll do at the end of the surgery. But don't put so much water, I can't see anything. मत डालो, मत डालो. Don't put anything.
Hello.
Yes, yes,
I received a question from a delegate.
yes.
Since you are now clearing the doubtful area, the question is what can be done to prevent the recurrence? I think this is the time.
Yeah, so basically one thing is you need to be very certain that you've got the whole tumor out first. Second is you should have an interface so you don't stop at removing only the tumor, you remove normal mucosa around it. So in this case, I have already landed up removing a lot of that normal mucosa while I was debulking that tumor. I showed you that near the roof, etc., it was mucosa. And third is wherever you feel that the origin of that tumor is, you need to think. See, now that I'm seeing this orbital fat, this other thing also is probably orbital fat. Can you see this other bit of, which I said looks like an inclusion cyst? That is also probably orbital fat.
Ma'am, we can press the orbit and we can confirm that.
There is a movement there.
Medial part.
Yeah. No, lateral is also moving. I don't want to press too hard. Can you see it moving? No, no, it is moving. I can't show you by doing it very thing. I don't know if you can see this. See, there's mucosa over it, so it won't move as much as just plain fat will. But there is a movement there. I don't want to do it. I'm doing it very, very gently. I don't want to remove that mucosa to check. Can you see tumor? This may be tumor or this may be even pterygopalatine fossa periosteum, but I'm going to drill that out. Also with the understanding that sometimes the sphenopalatine artery might open up there. Probably pterygopalatine fossa. I'll open it a little more. If it is widening away and is not narrowing down, then we know that there's nothing there. No, now you can see it's fat. Can you see this is fat? I was just checking to see whether there was a tumor or it's just fat. It's fat. Okay, so now what I'm going to do is, there's still a little bit of drilling I want to do here. This area still looks, see this looks normal and this looks still needs to be drilled. So I'm going to drill that area also. It's not functioning properly. Get another burr ready. Suction. Yes. I didn't follow what you said.
Can you go for a frozen section?
You can go. You can go. Today is Sunday. We don't have frozen section. Other than I've sent it straight Blakesley. An upward Blakesley. I'm looking closely at this also to see whether it's tumor or whether it's mucosa. No, it's mucosa. Okay, so what I'm going to do now, suction, is we'll do syringing, make sure that that thing is coming out, and then I think you're running short on time, others I'd have shown you opening up of the frontal sinus as well. Upward Blakesley. Straight Blakesley. Suction. Upward Blakesley. Now that we've opened the sphenoid, we might need to make sure that it stays widely open. So we will suction. Suction the. Sword, card. Suction. Give me a punch. पंच सक्कर आतमध्ये बाहेर आत पाय सक्कर ना Okay, so I've reached the roof. So this is, it's been, so it's completely, so I've opened up the, I've joined that onodi to the sphenoid. That's open widely. All this area I'm going to clean out. This, as you can see, is all normal mucosa. All this I'm going to clean out. How are we doing for time? Give me a syringe. Give me a lacrimal dilator. थोड़ा जगह देना है इधर. That's a lacrimal probe. Dilator कहाँ है? Lift up the upper lid. This is not a dilator. That there. Lift up the upper lid. Tu no ko. You. Show me light. Okay, give me the syringe. Let me come to the head end. Hold that there. Not. Wait a minute. Flush. Flush. Withdraw it slightly, then it will flush. Wait a minute. Flush. Hold that. Show me the light. You had butted it against the mucosa. Put the scope in. Wait. Show the. Can you see that? There's a little bit of pus. This is all because of dacryocystitis. You know what I'm going to do? Because I'm getting pus there, I'm going to open up that sac. Give me a keratome. I'm going to open up that sac because I'm not happy with what I'm seeing. Give me we'll take out a little more of that sac. Give me a turbinectomy scissors. Give me a ballpoint. Keratome. Keratome. Middle sickle no. I want a keratome. Give me a flush. Any questions? मोठं सक्शन दे ना. Yes.
I want to know the recurrence rate at your place. What is the data?
What is the data of recurrence rate? Actually, I have not actually done a proper study. So if I were to tell you from, uh, so if I were to tell you a scientific study, I have not done one in the recent years on inverted papilloma, but I'd say about 20%.
Oh, 20%. Yeah.
Not
And
this, the blue
so
one.
I in this area in
Yeah.
our Jharkhand, we are getting very high rate of recurrence.
Upward Blakeslee.
Mostly, we can say it is more than 50 and 60%. We
Uh,
can say we don't have the data exact, but it is. I don't think they are using a lot of tobacco here. That may be one of the reason. It may be viral. We are not very sure, but
uh,
the study is highly required, I think, to go for this. What is your suggestion? Because the recurrence rate is very high. Such a tedious surgery, and there is recurrence. More disappointing for me.
More likely it could be incomplete removal because 60% rate we
straight
have in our
Blakeslee.
ICC.
Um, there are two factors. One is, as you said, there may be genetic and patient-related factors, and two is, of course, if inadvertently, without realizing, something is left behind or the bone is not drilled out. So what I'm doing actually, because that MRI had shown involvement of the ethmoid. So I'm looking actually why I'm doing this is, of course, I'm going to make all that smooth and all that, but I'm really going slowly because I'm trying to see what the mucosa looks like, whether it's only mucosa or whether it is actually tumor. That is what I'm looking for. But so far I've seen, see this, it's edematous mucosa, it's not actually tumor. So that is why I was going slowly over there and looking. Yeah, so as far as recurrence rates are concerned, they're twofold. One is because of the genetic predisposition, maybe that region is more genetically predisposed to recurrences. And the other is, of course, if the basic principles of the surgery have been violated. So, for example, if we had not removed that part of the nasolacrimal duct, if we had not drilled, then the recurrence rates would, of course, be higher. Yeah, give me a
Ma'am,
strip. Yeah.
I have a question. Can we remove whole of the nasolacrimal duct, or is there then alternative to put some prosthesis or elastic tubing?
No, no,
What is
I would
what
want to
strategy?
remove, no, I would want to remove only that much which is involved. Is the keratome there?
Then does this patient need some prosthesis or elastic
Keratome.
tubing just to keep it patent?
No, I'm showing you what I'm going to do. Give me that now. Actually, the keratome that I use is a pointed one. They don't have it right now, so I'm using this one. This is not the ideal one. What I'm doing is I'm opening up the sac. Yeah, so I'm opening up the sac so that it continues to drain. Unfortunately, this is not the right keratome for this. It is very blunt. It should go in very easily, but it's not going in. Give me a patty. Ballpoint. Patties that one. Patty. Straight Blakesley. Can you see I've opened up the sac? Can you see the sac is opened? Yes? Okay, and it's edematous, but there's no tumor in it. It's normal mucosa. Can you see that?
Now you can have safety so that you can see the report.
Get that syringe again, ready. Straight suction the dada. So what do we do? What is the margins of maxillectomy? One is up to the lamina papyracea, up to the posterior wall of the maxillary sinus, up to the inferior nasal cavity. This I'm going to drill a little more. Give me a... so from the lamina papyracea to the floor of the nasal cavity, from the posterior lateral wall of the... from the posterior wall of the maxilla all the way up to the nasolacrimal duct. So that is what we have done. So this is which is what you'd call a classical medial maxillectomy. We've opened up the sphenoid and the ethmoids, and we're going to open up the frontal sinus. What are you giving me? What happened? What happened to the big burr? Not rotating. I'm drilling out all this bone because there was tumor there. It's not rotating. Give me another burr. It stopped rotating.
So
this.
Here I can ask this question this question has been forwarded by Dr. Kundan. What is the chance of recurrence for inverted papilloma after excision?
I already said that this is what is my personal... Burr again. Give me a curved maxi suction.
So exceptions are always there. So we have taken this tumor as a benign, but if it
Not
happens
working.
to turn out on biopsy malignant transition, so what can be the management after so much of excision done already?
That will depend on what you find radiologically on the repeat scan. So on the repeat scan, what are the areas involved? Those are the ones that you need to address. It will depend purely on what you find in the radiology. There is some amount of tumor here, I feel. Give me the debrider. Okay, give me the burr.
So on radiology, if we feel that we have cleared all the areas,
Yes.
so you mean that we'll only follow the patient? And
Yes, the patient has to be followed up both endoscopically and radiologically. Radiologically, at least one CT scan 6 months later. Where is it, the foot switch?
Tell us.
Yeah, so radiologically, a CT scan at least 6 months later. Speed badwa. What is the speed?
Hello. Excuse me, ma'am. Can radiology after 6 months expose the patient more radiation? Is endoscopy better
See,
than radiology for follow-up?
See, I would definitely do one CT scan 6 months, and then depending on that, maybe once a year. But the first follow-up at 3 months would be just endoscopy. At 6 months would be an endoscopy with CT scan, and then subsequently endoscopy, and maybe once in 2 years or 1.5. Means from that 6 months, another year later you can do a CT scan, and then maybe once in 2 years. So 6 months a CT scan, 1.5 years a CT scan, between endoscopic monitoring. Is it working now? तो चालतोय.
Are you hearing? Hello.
Yes. Give me a.
Renuka from Jaipur.
Hello, Dr. Anita.
Yeah. How many cases you come across of inverted papilloma in your day-to-day practice?
Routinely, we would say about 3 per 6 months, but since this is a referral center, we see them almost 2 to 3 in a month.
Okay.
Let's get that syringing, no? Then by the time you get the burn, hey, light dakho. Syringe.
Can some support there or is there some scope for that? Because the patient does not get enough thermos or it may increase
Oh, that orbital fat. That is too small. It will not cause any enophthalma. Too small. And it will mucosalize. Pushkar. Syringe. Can you see that syringing? Full tari bharaयचं. I don't. Fill again. Bhara full. Did you see or should I do it again? You saw? Okay, so fine. Suction. Give me the drill. This area is a little suspicious. I'm just checking on it. Yeah, thank you for getting it ready. This is the area of that greater palatine canal that I said to you. I'm just checking it out. So this bone has to be drilled, definitely. If you don't drill this bone, you'll get recurrence, okay? Because that's where the tumor was, along the inferior turbinate. Give me a upward Blakesley. So this is tumor. This is tumor. You see the way it peels off. Can you see how easily it peels off? Now I'll show you what normal mucosa does. See, it lifts up. It won't peel off. Can you see that? This is what happens to normal mucosa. But if it is tumor, it will come off relatively very easily. So this is that area which was involved. And I have to be careful I don't cause an oroantral fistula. So I have to be a little careful. Also I have to be careful that the greater palatine artery, keep a ballpoint cautery ready, that the greater palatine artery doesn't bleed. So I will go, now this patient will follow up very closely, because the chance of recurrence are higher here. But since the mucosa is not breached in the palate, I am not going to drill out that entire palate. Clean. Yeah, this is clear now. I'm getting normal thing. There's a little bit of tumor here. Can you see this? This is tumor. This is normal mucosa now. Give me. Suction. Give me a frontal suction. उसको लगाओ और नीचे फेस करो. See, now what you can see here is normal tissue, okay? There's no tumor. Little bit more anteriorly. Suction. And give me a cautery. I'm going to cauterize that entire area.
Madam, from Ranchi, Dr. Arkesha.
Yes. Yes, doctor.
These are regions for recurrence.
These are what?
These are the regions for recurrence. You have to be very minor to find out the left out tumor.
Yes, that's what I'm doing. I'm checking that. I'm making sure that at the same time I have to maintain the palatal mucosa. I can't breach that because otherwise I'll go beyond and it will go intraoral. Yeah, I'm reaching the palatal muscles now. Give me a cautery. Suction. Suction कर रहे हैं. No, suck the blood. Touch. बस. So now the last bit that I'm going to do is open up the frontal sinus. So I would leave it up to you whether you want to continue this broadcast or you want to continue with your scientific program. So I leave it, Dr. Dwaipan, you can decide what you want. I'll just continue operating now. 70 degree. I'll take any last questions if there are.
Most of the time I see you are using monopolar cautery. Why is that monopolar? Is that more beneficial than bipolar for these cases?
I see the bipolar you need where you're going to have CSF leaks or you're going to have orbital injury. That's where you need a bipolar. Everywhere else in the nose, whether it's the sphenopalatine artery, the greater palatine artery, if you're using a monopolar, even the maxillary artery, there is absolutely no problem with using it. It works fast, especially a ballpoint works very fast because it has a very small imprint. So it works very fast. It's very, you saw that sphenopalatine artery when it bled. It took just 30 seconds to control it. And there is actually no reason why. You know what happens with bipolar? You'll put a bipolar, then even though you're flushing it, sometimes that S charge sticks to the bipolar, that comes off. Sometimes the bipolar doesn't cauterize, as well, where you are not worried about lateral damage. See, when you're cauterizing the sphenopalatine artery, whether few millimeters of mucosa get cauterized or not, it really doesn't matter. In this case, so we have taken off the entire inferior turbinate. The middle turbinate is already gone. So if you're going to do a greater palatine artery cauterization with a monopolar, another 2-3 millimeters around it doesn't matter. Anywhere, suppose there's an anti-ethmoidal artery bleed, a posterior ethmoidal artery bleed. If there's something on the lamina papyracea, if there's dura, Suppose you open the sphenoid and the roof of the sinus has dura, then of course you'll use a bipolar. But anywhere away from the orbit and away from the skull base, you can use a monopolar very comfortably. A ballpoint will give you very quick results. So I don't think that there is any problem with using a monopolar. And if you see the regeneration, that I can show you about over hundreds of cases that I've done, that the regeneration of the mucosa is perfect. Not only is the regeneration perfect, but even the ciliary beat is absolutely normal. I can show you videos, I can show you stills whenever you want to, as many as you want to see. And none of these cases where you have extensive surgery, of course, the highest series of cases that I have done of vascular masses is angiofibromas, and you can imagine half the face is out, but we don't see crusting, we don't see atrophic rhinitis, except for patients who come from Rajasthan, whom we have to say that you continue to douche. But otherwise, the rest of India, I've never seen long-term crusting. Crusting for the first 3 to 4 months, and then it stops. And you get absolutely normal nasociliary beat.
Thank you.
Yeah. Frontal suction. Yeah, wait. Give me extension. Extension.
Renuka ma'am,
Yes.
are we going to put you in PIP because the inauguration has to take place?
Yeah, sure. Actually, Dwaipan, if you want your, sorry, give me a ballpoint. That thing I didn't. If you want, the inauguration, you can even close off. I don't mind. You can continue or you can close off, whatever. Just tell me what you're doing so I know.
Ma'am, they are going to start the inauguration. You will be live, but in PIP.
Okay, fine.
Right. Thank you so much.
Okay, thank you. Frontal suction. Upward Blakesley.
Good afternoon, everyone. So now we'll be having a short inauguration program followed by lamp lighting ceremony. So for this, I would like to invite our eminent dignitaries on the dais. So starting with the post director for Ascent AMG program, I would like to invite Dr. Doiman Mukherjee sir, Dr. Bradoo, past president of AOI, Dr. Ramandeep Vir sir, Professor EAP, PCI.
Debrider low. Upward Blakesley, upward Blakesley. जाओ ना हो कर बंद कर Hello, yes? Yeah, I can hear you. Yes? Just hold on. अरे बुलाओ ना उनको. I can hear you. Wait a minute. मेरा आवाज़ आना चाहिए. हेलो. 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 हाँ, yes. What were you saying?
Since we'll be moving on to the next session, any final concluding remarks from your side? You were able to see your surgery and you opened the fractal sinus.
Did you see the anti-ethmoidal artery? Okay, so then in that case, nothing more to say. You can see that that's the frontal, and just behind, below that here suction. That's the widely open frontal, and there was some suspicious tissue in that area, so I made sure that I removed. That's the anti-ethmoidal artery. It's a little dehiscent. Yeah, yeah. So that and the rest of the skull base here.
So you can follow it right up to the sphenoid.
Yes. Yes. That's the entire skull base, and that's following it all the way up to the sphenoid. And then give me a Blakesley straight. And the entire maxillary sinus completely drilled out. This was the area of attachment which I've drilled out. The lateral wall you can see is absolutely normal mucosa, so there can't be any underlying bony attachment under normal mucosa. And then we've taken down the maxillary sinus wall absolutely down and made sure that that greater palatine canal area also, which was suspicious, I completely removed till I could see normal muscle and mucosa. So that's what I've done. So in a classical, you've gone from lamina papyracea down to the floor of the nasal cavity from posterior lateral wall to the nasolacrimal sac, which I have opened up here in this area. I showed you by syringing. There's a little bit of orbital fat prolapse, which came as a bit of a surprise because no bone came out and just, yeah. So the tumor had eroded that little part, which is not seen on the scans. I'd have to go back and see it on the console or on the CD. But there is, as soon as I removed the tumor, you could see fat. And this, I personally, there's a little bit of doubt whether it is fat or cyst, but it's so close to that area, and I don't know if you can make out, it does move. Yeah. You know what, I can see it on the monitor that it moves. You may not be able to make it out exactly. It's a very fine movement. That's because it's covered by intact mucosa. But I feel that is also fat. You can see a very fine movement which is seen on the monitor. I can't press too hard as there's a fat will prolapse. But there's a very gentle movement, and I feel that that will also be fat. And so now we are done. I'm using something called an absorbable dressing along the skull base, along the lamina papyracea, and then I'm putting net cell in the area. So this is absorbable dressing, and then so on the lamina papyracea and along the skull base is absorbable dressing, and here I'll be putting marrow cell, net cell, whatever they give me. Yeah.
Thank you so much.
And these are the two areas where the arteries are. This is the sphenopalatine. You can see how it's see how much collateral damage is there. Hardly any. And this is an area where really you're not looking at millimeters. You're looking at centimeters actually of collateral damage. So I don't think, look at the amount of collateral damage we've done anyway. So another 2-3 millimeters of mucosa really doesn't make a difference. So I mean, you can use a coablator, you can use a bipolar. I've got all of that. But I think this works quickest and fastest. And when you've done such extensive surgery, 2 millimeters of mucosa cauterized more doesn't really make any difference. And I made sure that I've got normal mucosal margins everywhere.
Dr. Kripan from Kolkata, thank you very much for being here for the surgery. I know this is the festive season in your place.
Yes.
Everybody is appreciating for this wonderful surgery. I will like to request each and everybody in every center to give a big round of applause.
Thank you. I have Ganpati at my place, so actually today I was actually busy till almost 1:30 at night last night. So I go back to my celebrations now.
Yeah, yeah. Thank you very much. And this is help from personally from myself also. So you were in USA, you came back on Tuesday, and then you selected the case and operated today. So thank you very much. So any final comment regarding the program, regarding the surgery?
I saw,
Yeah.
Daipan, I saw the program. It is an exceptionally well crafted program, and I wish you all the best with it. And with your year to come. Okay, yeah.
Okay, so we will proceed for the next session with Dr. Ramani. Thank you.